Good evening, everyone. I want to thank you all for coming here on what is a weekday, and I'm sure everybody has better things to do, but this is an important concern of ours, and I'm here to certainly give the medical background. Well, just to give you a little background that Samantha already gave you, on March 23rd, 2014, World Health Organization was notified of an outbreak of Ebola in Guinea, a country in West Africa. In August, the WHO declared the epidemic to be a public health emergency of international concern. And this deadly outbreak continues to double in size every few weeks. So far, Ebola has been blamed for the deaths of nearly 5,000 people, 10,000 infected, the vast majority in West Africa. Again, this is just a pictorial cartoon of where the countries are. They're mostly on the western coast of Africa. We know that we had 3 cases that were transmitted from the original infection, 3 cases in the US, and the rest of them were, of course, flown from Western Africa for treatment purposes. So you can see the biggest concentration in Guinea, Sierra Leone, and Liberia. Now, just to keep in mind that there was another separate outbreak that was going on, and also in the Democratic Republic of Congo, where about 38 cases have been identified, but that kind of died down. That was a separate strain of the virus. Next slide. So let's go to patient 0, just to give you an idea how a simple thing can evolve into this deadly disease. So the first known victim of this outbreak was a 2-year-old Emile Wamuno. Did I say that right, Dr. Penny? Wamuno, who lived in a picturesque forest village with his parents and 3 sisters, including his 4-year sister called Philomene. The boy fell sick in December with a mysterious illness that caused fever, black stools, and vomiting. About a week after his death, his sister got sick and died. She was shortly followed by the children's pregnant mother and grandmother. So this is a picture of the family, the father, and this is one of the surviving sisters, after his 3 members of his family passed away. And I can tell you his life is never going to be the same again. So next slide, please. So what is Ebola hemorrhagic fever? It was previously known as Ebola hemorrhagic fever. It's a rare and deadly disease caused by infection with one of the Ebola viruses. And this virus causes an acute, serious illness, we know that, which is often fatal if untreated. Now we'll discuss the treatment modalities in a little bit. The current outbreak in West Africa is the largest and most complex Ebola outbreak since the Ebola virus was discovered in 1976. Next slide. So what is Ebola? There are viruses. They exist in nature. You know, they existed millions and trillions of years before mankind even existed on the planet. So it's primarily their home. And so I would say some of these viruses, they exist in Africa. A certain family of them is called the Ebola viruses. They cause disease in humans and other primates, meaning in monkeys, gorillas, chimpanzees, and the monkey family. So that's where the virus will infect them and cause a disease. And it's all called the Ebola virus disease or Ebola hemorrhagic fever or simply Ebola. Next slide. So there's 5 species of the virus, and the most important one is the Zaire Ebola virus. Second is the Bundibugyo Ebola virus, then Sudan Ebola virus, Thai Forest Ebola virus, and the Reston Ebola virus. The last one, Reston, does not infect humans, and it infects monkeys and chimpanzees. But although you can find a little bit of a serological evidence in man, but it doesn't actually cause disease. And these are named after the places that they were identified. Next slide. So the Zaire Ebola virus has the highest case fatality rate, and I will simplify that by saying that the case fatality rate is the death rate. Out of how many cases that were, how many patients were infected, how many died, it has a highest death rate, 90% in some epidemics, with an average of about 83% in 23 years. So you can see that very few people are expected to survive. And there have been more outbreaks of this virus strains than any other species. And this is the current strain that we are experiencing in this outbreak. It's the Zaire strain. Next slide. So how did Ebola get its name? That's a little bit of, to take the myth out of the word Ebola. You'll be surprised when you know what Ebola means. Does anyone? Okay. All right. So it was first identified in 1976 in a town which is called Yambuku, which is 60 miles from the Ebola River, and now in the Democratic Republic of Congo. And the 44-year-old school teacher became the first recorded case. And there was a professor, Peter Piot, he was from England and Belgium in the Tropical School of Hygiene. He was sent to find out what was going on. And so he actually named this virus Ebola, not Yambuku, because he did not want to stigmatize the village because this disease had such a grim prognosis. Next slide. This is the beautiful river Ebola. The original name was actually Legbola in the local language, and the French corrupted this name to call Liezl. And Legbola means white river, white water. That's what it means. And so this is the Ebola River. Next slide. So where are these Ebola viruses found in nature? They are found in several African countries, and outbreaks have sporadically appeared in Africa, and the national reservoir is questionable, but there is evidence to show that they exist in bats or fruit bats. And so they are the most likely reservoir, meaning to say that the bats can carry the virus in their bodies, but they do not get the disease. That's why the cycle continues. And so 4 of the 5 viruses, their host is native to the African continent. Next slide. So this is, I don't know if you can see this cartoon, but the main points are, this is the enzootic inner cycle amongst the bats. And when the cycle spills over to the virus, or the bat comes in contact with a wild animal or even a human being, the virus is transmitted to then what becomes the epizootic cycle. And when the wild animals come in contact with man, or bats, or human beings get either bitten by a bat or somehow infected by a bat, then the cycle continues in the human beings, and that's how an outbreak happens. So past Ebola outbreaks have occurred in the Democratic Republic of Congo, Gabon, South Sudan, Ivory Coast, Uganda, Republic of Congo, and the South African continent, when one of the lab workers actually was working and went to Johannesburg and got sick. So the current outbreak is the 25th outbreak after the first known since 1976, and this has killed more people than all the outbreaks previously combined. And I'm going to show you a cartoon towards that. So if you can look at, these are the different outbreaks. This is the one in 1976. That's how many people were infected, and how many people in the dark color, that's how many died. The mortality rate is somewhere in the ballpark figure of 80 to 90% here. And look at the number, and this is a little bit of an old slide. I mean, the numbers have grown since then. This is from September 26. Next slide. So here you can see another picture of the number of deaths as is much more than the total number of outbreaks combined. Next slide. So let's talk a little bit about the clinical features. So what is the incubation period? Just to explain to you, what is the incubation period? It's the time from when a person actually gets infected with Ebola to when he starts to show some symptoms. And so the incubation period for Ebola is 2 to 21 days after exposure to the virus, and the average is about 8 to 10 days. So I think there's a little bit of a generous margin there. So most people are known to fall sick about in 1 to 2 weeks. Next slide. So the initial symptoms are nonspecific. I want to point this out, and this is the big problem, because initially it feels like such an ordinary thing just for somebody to have fever that it's often confused with other things. And it's very difficult to sort out who may be infective and who may not be infective. So initially there's fever, chills, myalgias or muscle aches and pains, and a headache. And these can rapidly progress to gastrointestinal symptoms like severe watery diarrhea, nausea, vomiting, abdominal pain. Bleeding is present, but it's not universal. In fact, in this particular outbreak, and I'll show you, the incidence of bleeding was actually much less than previously. So, but the bleeding can manifest itself like bruising under the skin, like ecchymosis, or it may be a frank hemorrhage or bleeding from the stools or in the vomitus. And occasionally there's a rash. So the most common symptoms in the current outbreak have been a fever, so this is about 87%, and fatigue, and vomiting. And later, when you go back and look at the data, you sort of see it with a different eye, and you realize that fatigue was very often present in these patients, which nobody bothered to kind of look at it before. And also a loss of appetite. Of course, diarrhea, yeah. So then, if the patient is going to take a turn for the worse, then there is chest pain, shortness of breath, headache and confusion, conjunctival hemorrhage or redness, hiccups, seizures. Bleeding does not affect every patient with Ebola. In some cases, there may be internal, external bleeding, sometimes oozing from the gums and stools and vomitus, as I mentioned. So here's what the Ebola the typical path through a human being is days 7 to 9. Patients present with headache, fatigue, fever, muscle soreness. At this point, it could very easily resemble flu. And then day 10, there's sudden high fever, vomiting, blood pressure, passive behavior, patients are listless. And by day 11, there's bruising and there's brain damage and there's bleeding. And by day 12, they lost consciousness and seizures and massive bleeding and death. So next slide, please. So let's look at what lab findings we may find. The lab findings which we have, the collective experience of treating patients in the US has now led us to reveal a lot of things. So there's impaired kidney function, and it's severe electrolyte or salt deficiencies, low white count, platelet counts, which are different cells in the body. And the liver is damaged, and there's coagulation factors, the clotting factors are damaged, which explains the bleeding. So next slide. Something that I do want to talk about is the case fatality rate, or the death rate, if you please. And more severe the symptoms at presentation with Ebola, they predict a higher response to death. Most patients with fatal disease die somewhere between days 6 and 16 of complications, average to about 7 to 8 days. The average fatality rate is around 50% overall. 25% to 90% in past outbreaks, and the case fatality rate of the current outbreak approximately is 71%, 70 to 71%, and that's in West Africa. Okay. So I'm very happy to put this slide here. I'm very excited, so I sort of labeled it in red. So how do you recover? Does one recover from Ebola? Of course, one can recover. But it depends on a good supportive clinical care and the patient's immune response. Patients who survive the infection begin to improve around day 6 of the infection. Patients who recover, they will develop antibodies for at least 10 years. So they're protected, possibly longer. But are they immune for life, or are they immune to other strains of the virus? That's something we do not know at this time. And some develop, survivors develop complications like joint problems, vision problems, etc. So let's talk about how we diagnose this disease. So as I said, because the symptoms are so nonspecific, diagnosing it early is difficult. And these symptoms are often present in other diseases like malaria, typhoid fever, yellow fever, influenza, and I can tell you that the top 3 are at least very prevalent in Africa. So there's often a confusion. Next. So one has to have a high index of suspicion. I mean, that's the key. That if a person has early symptoms, then you go and check the history. Did they have contact with a person who had the symptoms of Ebola, or was exposed to blood and body fluids of a person who's sick with Ebola, or was in touch with or contact with objects that had been contaminated with body fluids of Ebola, or was in contact with infected animals. And then once you get your suspicion, then you can go for rapid testing and isolation and make a diagnosis. Next. So let's not get carried by this medical mumbo-jumbo, but this is a timeline of infection. In the early few days, you can do some testing. And later in the disease, you can check antibodies the patients had produced. And retrospectively, of course, you can do PCR and some staining and even isolate the virus. But the most common test we rely on these days is the polymerase chain reaction, that is looking directly at the genome of the virus, the DNA. You amplify it, you match it with your existing profiles, and then you make a quick diagnosis. I have something very exciting to tell you here. I think it's after this slide. Wow, I just got this morning. So this is a simple new test that finds Ebola in 15 minutes. That could be a game changer. Yeah, so this is something I should have quoted in red. But so the Tulane University scientists have created an Ebola diagnostic device they say is easy to use and nearly as fast as the home pregnancy test. Takes only a drop of blood in 15 minutes to identify the disease. Another firm in San Diego has a similar test that says they can do the test in 10 minutes. And this is awaiting, of course, federal approval before it can be used in West Africa. It's sorely needed. We know testing is sorely needed in people from spreading this deadly virus. And some things that I was going through in the West African response, and Dr. Penny can talk more about it, is the problem is not taking the blood and doing the test. It's often the transit time from taking the sample, and driving or taking the sample to a designated center. That may take days. The test itself takes about 3 to 4 hours, the PCR test. But it's that. If you could have a kit at ground level and right at the source, I mean, you could just quickly quarantine the patient or isolate the patient and prevent things from happening right there. So this is something very exciting. Okay, so next slide. So let's talk about the dreaded word, transmission. Okay, so how is it spread? Ebola is spread through direct contact. I mean, that's clear. It's spread through direct contact, but that direct contact can be interpreted in different ways. I have to tell you, it's not transmitted like SARS or the flu. So it's through contact with broken skin or mucous membranes, for example, the eyes, nose, or mouth with blood or body fluids, including urine, saliva, sweat, feces, vomit, breast milk, and semen. And objects like needles and syringes that have been contaminated with the virus. And I think the first 1976 outbreak that went out of control was because of contaminated syringes from the first patient. And infected fruit bats or primates, of course. So humans are not infectious. This is important. Humans are not infectious until they develop symptoms. And the higher risk period is when there is vomiting and diarrhea. So let's not all panic with, somebody that presents with fever, oh my God, am I getting infected? So there has to be a lot more going on for the patients to be infectious. And all the patients who were here and the 2 nurses who were diagnosed here goes to show that their family members didn't come down with Ebola, their fiancé or fiancés, or partners did not come down with Ebola. It's just the medical health workers who were in touch with them and their secretions while taking care of them. Next slide. So as I think Pastor Saul pointed out, the sad reality is that the Ebola cases, there's a disproportionate, I wouldn't say disproportionate, but a high number of healthcare workers that land up being, getting infected with this, and that's a sad thing. The very persons who are taking care of you become the victims of the disease. So you can see that there were about 416 cases diagnosed and with 233 deaths, so 50% of healthcare workers. And we lost 2 of our own doctors. Okay, so transmission to healthcare workers, so I will put a little emphasis on it, that healthcare workers providing for and caring for Ebola patients and family and friends with, and their friends and close contacts. Now we have to define close contacts. Are at the highest risk of getting sick because they come in contact with this blood or fluids. Especially during the outbreaks, disease can spread quickly, especially when hospital staff are not wearing the appropriate equipment. And again, goes to show quick diagnosis and isolation is key. Next. So Ebola is not spread through the air or by water or in general by food. However, in Africa, Ebola may be spread as a resulting of bushmeat, wild animals hunted for food, and contact with infected bats, but not food in general unless it's acquired from there. And there is no evidence that mosquitoes or other insects can transmit the Ebola virus. Next. There's also no evidence that, I did speak about the mosquitoes. There's no reports of dogs or cats becoming sick with Ebola or being able to spread Ebola to people or other animals. I mean, that's just, there isn't enough evidence to tell us. There is a limited evidence that dogs become infected with Ebola, but whether they transmit it back to humans or to other animals is just not known. There's no evidence. Next slide, please. So this is an important slide, and I just want to, I think it will help quell some of the panic and hysteria that's spreading because of Ebola. If you look at the transmission rate of viruses or any other microbes, there's something called the RO factor, meaning to say, does the virus, how many other persons does it infect? Does it have the capacity to infect? So you look at the hepatitis C virus in general, it would infect 2. Ebola, again, would infect 1 to 2, and then of course that multiplies, whereas HIV, the rate was approximately 4, SARS 4, mumps 10, and look at measles, 8. You just have to have one patient with measles could infect 18 people right there. So just to put it in perspective a little bit. Next slide. And again, I just want to emphasize the way we isolate patients in hospitals is either contact isolation, droplet isolation, or airborne isolation. And you can see that the size of the droplet matters, and the smaller the nuclei, the farther the virus can travel. And so if you look that the Zaire Ebola virus is on the left side, it's about 1 meter. If you have been within 3 feet or 1 meter of a person, then theoretically they could spew the sputum or snot and it could fall in your body, and then you could get Ebola. But not as if you're a distance of 10 meters. If say I'm watching some of you and somebody has Ebola, I'm not going to get it. So that's a good slide. Okay, next slide, please. So just wanted to bring this out. We have talked about it at our own meetings, how with the onset and advent of flu season, how this is going to be a worse conundrum for all of us. Anybody presenting with fever, who may or may not have come in from West Africa, I mean, did they have the flu? So this is a logistical problem that we have to attend, and we have to be ready in time with early, quick diagnosis of flu. So some of the things, and there's no hard and fast rule to say, so testing has to be done. So Ebola has more GI symptoms, and the flu has more respiratory symptoms. But again, a quick test would rule that out. Next. So let's talk about treatment. There are no approved treatments for the Ebola viruses. Whatever you've heard in the media have been experimental drugs that were released in the case of an emergency and the emergent outbreak. And a disease is treatable actually with a mix of standard and invasive medical techniques. So next slide, please. Are there drugs to treat or prevent Ebola? So they are in development. None is approved yet. Several have been approved for emergency use, and there was a drug, ZMapp. Actually, it was not an antiviral drug. It was just a combination of antibodies that was developed and provoked, and it was partly done and produced in plants, and we soon ran out of the supply, and we could not give it to, for some of the patients who were presented later in the US. So next. So all the meetings that we've attended have said that if you treat it like an acute case of sepsis, we already have protocols of how to treat extreme infections. If we can support the patient during that with aggressive initial treatment, we are almost certain to save lives. So there's hypovolemia and shock, which means to say the blood pressure falls down, we lose a lot of fluid from vomiting and diarrhea, there's dehydration, there's salt electrolyte problems, there's lack of oxygen, there's hemorrhage and bleeding leading to more shock, and then there's multi-organ failure. So what do? You replete volume and maintain the blood pressure. So at this point, I would say that most patients who are treated here sometimes need 5 gallons of fluids pumped into them on a daily basis. So in 5 gallons. And because there's extreme shock and extreme sepsis. And for that, a peripheral IV line is not going to work. So you need central lines. So the order of the first line of treatment is as soon as a patient is brought to you, just go in, put in a big line, and just pump and dump fluids. That keeps the heart and the organs going. And volume repletion, large volume, take care of oxygenation, take care of pain control, nutritional support, treatment of other bacterial infections, and treat pre-existing comorbidities. Having said that, there was one thing that I meant to put on here and I didn't, and I'll talk to you. Important thing is to stay connected with the patient. The problem with Ebola, and I read this morning again, it's a no person legacy, that in your extreme last moments, you are not being able to connect with your family or the people that you love because you're mortally scared of getting infected, and that's partly the problem that has escalated this outbreak. So contact with them, emotional support is very important. So the lessons learned are that the paradigm shift from it's a death sentence to it's a beatable disease. Certainly, that has been proved true. Early detection is crucial. Early aggressive treatment is important. The challenge is to keep the patient alive long enough for the immune system to vanquish the virus and return to normal. So next slide, please. Now, let's talk a little bit about vaccines, and this is going to be quick because, so next slide, please. So there are studies that in non-human primates, which means the monkeys or apes or chimpanzees, there is proof that the vaccines work. So we have reason to be optimistic. And this is an article that was just published in October 2014 in that chimpanzee virus vaccine generates acute and durable protective immunity against Ebola virus. So on this last month, the WHO had convened an urgent meeting of how to produce an Ebola vaccine. Next slide, please. So there are two candidates. One is CAD3 from GlaxoSmithKline, and they are already done their phase 1 studies. The phase 1 studies means, is it safe enough? So certainly phase 1 studies are completed. The second phase would say, are they effective enough? And so that's going on. And there's another vaccine that's produced by an agency in Canada, and they plan to begin enrollment soon. Next slide. So this is one of the vaccine candidates. And so data from clinical trials shows that the data is going to be back by December, next month. Oh, actually, it's October still, so December. Even if there is adequate safety and immunogenicity is demonstrated, the vaccine is not going to be available till the first quarter of 2015. And WHO has announced as many as thousands of doses could be ready for testing in January. And the real-world testing would start after there are trials and data from Africa, Europe, and the United States. So let's talk a little bit about prevention. So again, I emphasize this again, for prevention is important because the healthcare workers are so vulnerable. So you can see that there were 404 cases of Ebola in healthcare workers and 232 died. Next slide. So how do you want to reduce the risk? So you reduce the risk of the wildlife to human transmission, you reduce the risk of human to human transmission, and you do outbreak containment measures. So you restrict contact with infected fruit bats or monkeys or apes or consumption of the raw meat. Animals should be handled with gloves and other appropriate protective clothing. Animal products and blood and meat should be thoroughly cooked, if at all, before consumption. Avoid direct contact or close contact with people with Ebola symptoms, particularly with the bodily fluids. Gloves and appropriate personal protective equipment should be worn when taking care of all ill patients at home. Regular hand washing is very important, so these are just common sense things after you visited patients in a hospital as well as taking care of patients at home. Prompt and safe, so outbreak containment measures, prompt and safe burial of the dead, identifying people who may have been in contact with somebody, monitoring health contacts for 21 days. And this has led to some media frenzy, which we can address later. Importance of separating the healthy from the sick to prevent further spread, quarantine measures, and a good hygiene and clean environment. Next. So the question is, are we ready? We are more than ready, I think. We're hysterical by now. So that's the whole. So here are the CD has ramped up their quarantine centers. So there are 20 quarantine centers, and this is a little map of where we can quarantine them. Next slide. So these are the state public health has increased their sites where blood samples could be sent to rapidly make a diagnosis. So hospitals have been designated to accept Ebola patients, of course, in Atlanta, in Chicago, in Nebraska, Denver, Long Island, and Bethesda, of course. And there's a travel alert for going to countries in West Africa. So there's a level 3 hazard level. This levels 1, 2, 3. Level 1 is regular precautions. Level 2 is enhanced precautions. And level 3 is you restrict travel unless you absolutely need to go. CDC urges all citizens to avoid unnecessary travel and travelers to protect themselves by avoiding contact. Okay, so these are the nation's 5 airports that are screening travelers returning New York, New Jersey, Washington, Atlanta, and Chicago. So, and there are restrictions, and I'm not going to go into the hysteria of what's been happening lately in the media, but a quarantine, every state is now beginning to formulate some kind of quarantine for each of the states. Sometimes that does not align with what the CDC says, but okay. And so see that these are the CDC guidelines, protective personal equipment. I did not go into that, but I can answer any questions later. That in the hospitals itself, there have strict guidelines of how you're supposed to garb if you were to see a patient with a suspicious case of Ebola. So it is the policy is to show no skin. So it has to be a full protective suit, shoe covers, goggles, a visor not to get splash in your eyes, and double gloves. Okay, next. So I will end my talk by saying that, as Benjamin Franklin said, an ounce of prevention is worth a pound of cure, and certainly this is very true here. And I would say that if we can treat Ebola at its source and prevent it from there, is much, I think, better if we, try to and prevent as many cases as possible. Thank you.